emergencies. With this exemplar, we're going to be still looking at gas exchange, but we're looking specifically at pneumothorax. The nurse arrives in the client's room to discover the client is cyanotic and diaphoretic. Based on this information, what priority care will the nurse anticipate? Okay, so let's look at this together now. We need to do a quick reassessment. So we're looking at cyanosis and diaphoresis. We need to start with the respiratory system. Let's get an oxygen saturation, a respiratory rate, and pattern. So as we are watching their chest wall movement, is it symmetrical? Are they using accessory muscles to breathe? Are they having shallow breaths? Are they having deep breaths? We also need to know the rate of those respirations going on there. Are they really struggling to breathe, etc.? We need to listen to those lung sounds. But in addition to that, we also need to get a heart rate and blood pressure. We need to determine if that cyanosis is because of a respiratory issue or a cardiac issue. On top of that, we also need to do a quick assessment of pain and location, the level of consciousness, which would indicate if they're hypoxic, etc. So after doing that, we definitely need to elevate the head of the bed. Then we're going to initiate or increase their oxygen therapy. After doing all of that, then we need to do another quick reassessment. Did that make a difference in the cyanosis? Did it make a difference in the oxygen saturation? Is my client doing a little better? Is it the same? Then I notified the healthcare provider. So a pneumothorax. First of all, what is a pneumothorax? This is basically air in the pleural space causing a lot of negative pressure in the chest cavity. We have a rise in chest pressure and a reduction in vital capacity. This causes a collapse of part or all of the lung. It's often caused by blunt trauma or a penetrating wound from a stabbing, a gunshot. It could also be a complication of a medical procedure, such as starting a subclavian IV and the needle slipped and we punctured the lung. It could be caused by a rib fracture. Pneumothorax can also occur spontaneously. A pneumothorax can be open, where the pleural cavity is exposed to outside air through an open wound in the chest wall, or it could be closed. If bleeding occurs into the chest cavity, we call that a hemothorax. If the bleeding is less than 1,000 mLs of blood, we consider this to be mild, but if it's greater than 1,000 mLs of blood, we consider this to be pretty severe. Then we have a tension pneumothorax, which is a life-threatening complication of a pneumothorax. This occurs when air enters the pleural cavity during inspiration, but it does not exit during exhalation, and this increases the chest pressure. The lung is completely collapsed, and blood vessels are then compressed by that increased air pressure, which just continues to rise with every inhalation. It will lead to decreased filling of the heart and decreased cardiac output. And eventually, it's going to cause compression of the heart and pushes all of the organs inside the chest to the opposite side. We call this a mediastinal shift. And with a mediastinal shift, you'll start seeing tracheal deviation. So let's say that the pneumothorax is on the left side. It develops into a tension pneumo. Everything is pushed to the right side. So the trachea will also be pushed to the right side. If it is not promptly detected and treated, it will be fatal. Symptoms of a pneumothorax include chest pain, shortness of breath, tachypnea, hypoxia, reduced or absent breath sounds on the affected side, hyperresonance of percussion, except with a hemothorax, which then we would just have a dull sound, minimal to no chest wall movement on the affected side. With severe cases, again, we see that tracheal deviation and the mediastinal shift. With the tension pneumothorax, we have additional assessments, and this would include severe respiratory distress and cyanosis, distended neck veins, tachycardia, hemodynamic instability, and respiratory failure. So what do we do about it? Our goal, of course, is to evacuate that air or blood from the pleural space. If it's just a mild pneumothorax, it may not require any treatment, just monitoring. If there's an open wound, until provider treatment is available, it's important to cover that open wound with the sterile vented dressing, meaning that we're going to tape the dressing on 3 sides only, and this will allow air to escape, but it does not allow air to re-enter that pleural space. Oxygen therapy, pain control, pulmonary hygiene, which is going to include those breathing exercises, coughing exercises to help keep those airways open and those alveoli expanded. We're going to monitor vital signs and the respiratory status especially. With a pneumothorax, this may require a needle thoracostomy in the second intercostal space to release air. Chest tube insertion. This usually goes in about the 4th or 5th intercostal space. Then we connect it to a water seal drainage system until that lung reinflates. We may connect it to wall suction, and we may not. It does not have to be, but sometimes it can kind of speed things up a little bit. The chest tube will be connected to several feet of tubing that is then connected to a collection device. Make sure that you securely tape these connections. They are easily dislodged, so it's very important to tape them. Clients can have more than one chest tube that is connected to one collection device using a Y connector. Usually this collection device will be a disposable unit with 3 chambers. We have the collection chamber, which is where all of the air and or blood or secretion will collect. Then we have the water seal chamber, which will prevent air from moving back into the tubing and the chest. And we have the suction chamber. The collection chamber can be marked with a permanent marker every shift to help indicate the drainage level, so we can keep a measurement for our intake and output. But if it becomes full, some of these devices have removable collection chambers, and you can put an empty one in after removing a full one. The water seal chamber has 2 centimeters of water, and As that air is evacuated from that pleural space, then we're going to see a little bit of bubbling, but it should not be continuous. If it's continuous, then that means we may have a leak in the system. If it's intermittent, then it could just be the air escaping. But once that lung is fully expanded, we should no longer see any bubbling. Now, if the tube is blocked, maybe there's a blood clot in the tubing, or maybe there's a lot of secretions there in the tubing. Maybe the tubing is kinked or the client is lying on the tubing. The bubbling will, or there won't be any what we call tidling. So once again, if bubbling occurs in the water seal chamber after the lung has re-expanded, it does indicate an air leak. In that water seal chamber, we see what we call tidling, and this is normal. Tidling is the rising of water with inhalation and the lowering of that water with exhalation. So again, absence of tidling may indicate we have a full re-expansion of the lung, or there's some obstruction, such as the client lying on the tubing. Then that third chamber is what we call the suction chamber. The amount of fluid in that suction chamber will be determined by the provider, and it can be connected to wall suction. How do we know how high to turn it to? Well, whatever the provider tells us, or we turn the suction up until we see a gentle continuous bubbling. So continuous bubbling in the suction chamber is expected. It is important that we assess the system hourly, monitoring for leakage or drainage. We need to keep sterile gauze and padded clamps at the bedside just in case this becomes disconnected. The end of the tube, if it becomes disconnected, could be placed in a cup of sterile water. This will then work as a water seal to help prevent any air from getting back into the chest cavity. We will be doing serial chest x-rays to monitor lung reinflation. Once the client is stabilized, usually those are done on a daily basis. It is very important to keep that drainage system in an upright position and lower than the insertion site. Clients can sit in the chair and or ambulate with the chest drainage system if they are stable and if there are no contraindications. We do keep a dressing around the chest tube insertion site, and it has to be occlusive. We want to prevent any air from getting into the chest cavity. So usually it will be wrapped with a petroleum gauze, and then we cover that gauze to prevent any air getting into the cavity, or some type of a hydrocolloid silicone foam dressing. This is not a daily dressing change. We can reinforce it if we note some leaking. It will be changed, but it is changed as infrequently as possible. So every 3 to 4 days instead of every day. Complications. These clients can develop a tension pneumothorax. Another complication is what we call subcutaneous emphysema, where the air leaks into the tissue. And this can cause edema where the leak has occurred. So if you look at the picture on the slide, look at this gentleman. You see that edema to his face, to the eyelids, etc. That would be the subcutaneous emphysema. When you palpate an area, and sometimes you'll feel it like on the chest or the neck, these are the really common areas, not saying it can't be anywhere else, it's going to feel and sound like Rice Krispies or popping of bubble wrap. The body will gradually reabsorb that air, but severe cases may require placement of a tracheostomy. So let's go ahead and look at these pictures. In the left lower corner, you have the picture of a type of drainage device. This one happens to be a plurivac. In the middle, underneath the pictures of this gentleman, we have what we call a Heimlich valve, which can sometimes be placed. It will allow air to escape, but as the client inhales, it kind of seals on itself and will not allow any air to get in. And then you can see the picture of that hemovac or Heimlich valve. I'm sorry, I called it the wrong thing. A Heimlich valve um, that has not been placed on someone.